Parents, we're so lucky to have Dr. Greenberg here today. He is an expert in AFM, and he is definitely a celebrity on our site. we have a lot of parents who say, oh, I'm going to see Dr. Greenberg. What questions can I bring from all of you? And so we really appreciate all you've done to take care of our kids. So we'll go ahead and just let you get started, and then parents just feel free to ask questions along the way. This is supposed to be super interactive. And just to remind everybody, we are filming this. There's nothing about your names or phone numbers or anything that will show up on the recording. So just know that, okay, for your privacy. All right. Thank you so much, Dr. Greenberg. The floor is yours.
Sure. No, thank you for having me. If I am anywhere close to a celebrity on your website or Facebook page, you need a new Facebook page, because that's a very bad sign. As you and I were talking before the recording started, I came to Dallas in 2009, and our clinic, our myelitis clinic, opened up down here then. We were seeing kids at Hopkins in the years before that, and as we look back over history, the flaccid myelitis, the acute flaccid myelitis variant of myelitis has been present for years, and just not in the same numbers as we saw in 2012 or 14 or 16. But it's something that's definitely been around, and so we've been handling the issues that you and all the families out there have been challenged with now for quite some time. We're just better at understanding what we're looking at, phenotypically and hopefully scientifically, understanding the differences between lots of kids who are lumped together with one diagnosis. One of the things that's caused a lot of confusion and consternation has been around the diagnostic titles, the words that are being used when talking about kids or adults with these conditions. And I'll tell you that the framework we've been using, and that we're putting into a new, it's called nosology, a new defining criteria for these cases, is to zoom the lens back just to talking about the notion of myelitis, inflammation in the spinal cord, whether it's attracted by an active infection or if it's there for the wrong reason, autoimmune reasons. Regardless of the instigating factor, there's inflammation in the spinal cord. And what's differentiating the acute flaccid myelitis from what has dogmatically been taught to doctors about what was called transverse myelitis was which parts of the spinal cord were being affected. What's caused a lot of problems is the use of the term transverse myelitis, which is a term most neurologists have hated for a long time because it's really an awful term. Where it comes from is the 1940s, 1948. There was a paper written by a neurologist, and up until then, the term myelitis, just inflammation of the spinal cord, had been used in the literature. And what this neurologist described was a kid with myelitis, but who also had a sensory level, who said, Dr. Greenberg, from here down, I can't feel. And he used the term transverse to talk about that sensory level, and the name stuck. But as this group knows, as the community of families who've been affected by acute flaccid myelitis know, there are different parts of the spinal cord that can be affected by inflammation. And if you affect the anterior horn cells, the group of cells in the front of the spinal cord, the very beginning of the nerve that's going to go out to the muscle, you get one pattern of weakness. Whereas if you affect the cells in the spinal cord that are connecting the anterior horn cell to the brain, you get a different pattern of weakness. And in one child, you can have both patterns. You can have a limb, an arm, for example, that is loose and floppy and weak, and then you can have legs that are weak but stiff. And those differences represent the different parts of the spinal cord that get affected. And so for years, we were diagnosing kids who we would now diagnose as acute flaccid myelitis. We were just diagnosing them with the term transverse myelitis, when in actuality, these are all related. And they're all forms of inflammation in the spinal cord. Now, ultimately, what we want to get to is the root cause for all these different types of forms, and we can talk about that. And then, obviously, the different mechanisms for recovery, because what we do for children who have weak but tight muscles versus weak and floppy muscles is totally different. And so the avenues for rehabilitation are different in those two groups. And then ultimately, what we do from a technological perspective, the science of inducing repair, whether it's with drugs or cells or any type of therapy to induce repair, is going to be different if we're trying to repair someone who lost that anterior horn cell versus somebody who lost the connection of that cell to the brain. And so sorting out the patterns that are happening to each of our kids is going to be important, because some kids will qualify for certain interventions while those may not help some segments of kids, and we'll need to go a different route. But I'm sure this has been the subject of a lot of discussions online in terms of these different titles. And we take a very broad approach and just say myelitis, and let's figure out what limb has been affected in what way.
Thanks for clarifying that. I think that's huge, and it is definitely a subject of confusion.
Yeah.
Especially as parents then think about, if there's myelitis, is there also brain involvement? And then they, and if you could just clarify sort of the spinal cord pure involvement as opposed to conditions that also affect the brain, maybe with optic neuritis or something like that. I've seen some parents have questions about that. Is this a form of MS or NMO, et cetera?
Yeah, and this is where the semantics, the way we name things, really box us in tough ways. So myelitis as a term is a combination of anatomy and physiology. All the word means is inflammation in the spinal cord. So if I have somebody who has inflammation in the spinal cord and the brain, do they have myelitis? Yes, they have myelitis, but they also have inflammation in the brain. So the problems with naming conditions, so if I say that somebody has Huntington's disease, we have defined Huntington's disease to be a genetic condition with a mutation in a certain gene that leads to the following symptoms. When we name conditions based on the anatomy and the physiology, everything goes to hell, because there are no clean differentiations. Let me give you an example. So pediatricians, and I love the pediatricians in the world, I'm not a pediatrician. So some people online may not realize this. So I'm an adult boarded neurologist who did neuroimmunology training, and then about a decade ago, a little more, unfortunately, getting old, transitioned to see both adults and kids because I was treating rare diseases. Neuromyelitis optica, acute disseminated encephalomyelitis, things that transverse myelitis, things that were affecting both adults and kids and were rare, so I started seeing both adults and kids. When I moved to, and this was at Hopkins, when I moved to Dallas, I walked into a situation where there was nobody on the pediatric side seeing these kids. All of the children in North Texas were driving to Houston to see a spectacular clinician down at Texas named Tim Lawson. And so all of our kids in North Texas with transverse myelitis or multiple sclerosis were going there. So when we opened our clinic in 2009, we opened a pediatrics focus center. I have a dual appointment in the Department of Pediatrics, but that was somewhat of an honorary title because I am an adult boarded neurologist, and I focus on just these conditions. One of the things I learned, however, why am I telling you this? One of the things I learned, however, was my pediatric colleagues love to apply the term ADEM, acute disseminated encephalomyelitis, to any kid who had inflammation in their central nervous system. So if a child came in with inflammation in the brain, inflammation in the spinal cord, or both, they would just get the label acute disseminated encephalomyelitis. And I came in and I was a stickler. When I first got here, I was very much a stickler for semantics. And if a kid came in and the inflammation was only in the spinal cord and didn't affect the brain at all, I would say, no, this is not ADEM, this is transverse myelitis. And then I'd say, all right, now as we get to 2012 and 14, there are different forms of transverse myelitis. The acute flaccid myelitis form versus the more classic white matter form. Well, it turns out I need to stop being a stickler because what we're finding is a lot of kids who on MRI look like they have isolated inflammation in the spinal cord. Clinically, we can find evidence that they have inflammation outside the spinal cord. And we've done some studies on this. If we do cognitive testing on children who have had isolated by MRI, isolated inflammation in the spinal cord, we can pick up that there may be some brain functionality changes. And so we're revisiting this in our new nomenclature that we're trying to get put together and out there on how do we handle individuals who have brainstem and spinal cord involvement. And how do we sort out what are the patterns that should make us concerned for multiple sclerosis versus neuromyelitis optica? And we're getting a lot better at it. So multiple sclerosis in kids who have had the acute flaccid myelitis variant of myelitis, we are not seeing any of the risk factors for multiple sclerosis. And I am unaware of a single case of a child who had a presentation of acute flaccid myelitis who later went on to meet the diagnostic criteria for multiple sclerosis. So right off the bat, that is a very low concern we have in our clinic. Secondly, neuromyelitis optica is a little different. Neuromyelitis optica and the presentation of acute flaccid myelitis can overlap. There are definite cases where we look at the MRI and we look at what's happening clinically, and we ask ourselves, geez, could this be a first presentation of neuromyelitis optica? And in general, all of our kids have been testing negative for the antibody that has historically been associated with neuromyelitis optica, which is called the anti-aquaporin 4 antibody. Everybody needs to stay tuned over the next 6 months because a second antibody has been discovered that can cause the syndrome of neuromyelitis optica. It is more prevalent in kids than adults. And in our hands, we are seeing kids with this antibody, but they are not presenting as acute flaccid myelitis. This antibody is called the anti-MOG, M-O-G antibody. We expect to have a commercial test out on the market sometime in the fall. The Mayo Clinic's been working on one. Oxford has one. Several groups have been working on this. And when we have applied the test to our cohort of kids here in Dallas, the kids who are testing positive are the ones who have presented with a lot of brain inflammation or bilateral optic neuritis. In the kids who met the classic definition or phenotype of acute flaccid myelitis, I am not seeing them test positive for this antibody. And so if you have a child who had a lot of spinal cord inflammation that led to anterior horn cell loss, they have a flaccid weakness, a floppy arm or a floppy leg, the likelihood of this being a condition that has recurrences is extremely small. To my understanding, and I've looked at our database and others, I cannot find a single child who had acute flaccid myelitis who had recurrent inflammation later in their follow-up. And we've got kids at least a decade out now, and we haven't done any case of a recurrence. And the key is fitting into that initial criteria that there was some form of flaccid weakness, a loose, floppy limb of some kind that needed to be part of the presentation for us to sit back and rest assured that there's not a high risk of recurrence.
Okay, thanks so much for clarifying those different types of presentations and terms. One other thing I see a lot from parents is the question of, I've been reading and this sounds an awful lot like real polio. How do we know it's enterovirus D68 or some other virus and it's not just polio? And so sort of distinguishing for us what's an enterovirus, what's polio, what's a poliovirus would be really helpful, I think.
Yeah, I actually think that's sorting out causation is going to be critical for all of this. I'll tell you what what I think, what I know, and what I think we can prove, and those are all very different things. Mm-hmm. So I do not think this is either wild type or a variant of the polio virus. Mm-hmm. The reason is the investigations that have gone on.
And actually, I'm so sorry to interrupt. Just could you explain sort of what an enterovirus is and how polio is one of those?
Yeah, absolutely. Okay. So viruses so what's a virus versus a bacteria? All these different infections. So what makes something a virus by definition is it needs a host cell to replicate in. So a bacteria can replicate on its own. It's got its own nucleus, its own DNA, but it's also got machinery to make proteins and replicate. So a bacteria doesn't require another host to replicate. A virus is DNA or RNA encased in protein, but it doesn't have the ability to replicate unless it gets into a host cell and use the host cell machinery to replicate. So if I take all the viruses of the world, they fit into different types of viruses. So some viruses have a genetic material similar to what you and I have, to what humans have, of DNA. And then the DNA gets made into RNA, the RNA into proteins, and then the proteins make the superstructure of the virus. Other viruses have no DNA whatsoever. They only have RNA. So they skip a step. So they have the RNA as the genetic material. They get into a host cell, and that RNA gets used to make proteins. So right off the bat, we have DNA viruses and RNA viruses. And then within each of those groups, we break them down further based on a whole host of different qualities about the viruses. So people here have heard of influenza. People here have heard of polio, rabies, mumps, measles, all of these different viruses. They each have families that they belong to. And so these families are defined by certain characteristics of the virus. Was it a DNA or RNA virus? Was it of a certain size? Did it have certain proteins? There are a group of viruses, a family of viruses called the enteroviruses. And within this family, there are different subtypes of enteroviruses. And so everything from the poliovirus to the rhinovirus, which can cause the common cold, are all related because they share a certain type of single-stranded RNA and certain other qualities together. So they're all cousins of each other, but they have distinct differences between them that break the cousins into their own families. It's like the difference between first cousins and second cousins and third cousins. And so you have a group of enteroviruses within the enterovirus family and a group of polioviruses, and they're considered first or second cousins. And so we can, when looking, differentiate a poliovirus from an enterovirus based on its genetic code. We can look at it, we can sequence it, and we can say, here's the difference. Or if we grow it up in a dish, we can look under an electron microscope and the structure of the virus looks different between the two. So lots of different ways to tell the difference between them. It turns out, and this is the critical piece that causes a lot of the confusion and consternation among scientists and the CDC and everybody else, it turns out RNA viruses are very difficult to capture and grow out of a human specimen. And so when we look at, for example, spinal fluid, it is very rare to isolate RNA viruses, even if we know there was an RNA virus there. And the best example of that is actually polio. So if we go back in time, and we go back 100 years before the major outbreaks of polio, there were outbreaks of polio happening, but not the 5, 10, 20,000 kids at a time outbreaks, but 100 happening. If we look back at the efforts to try and sort out what was causing it, scientists back then would look at blood and look at spinal fluid, and they couldn't get the virus to move from one person or one animal to another. And there wasn't an ability to replicate the syndrome of polio by using spinal fluid. They had to literally so if they were doing experiments in monkeys, for example, they literally had to take the spinal cord of a monkey that had polio, grind up the whole spinal cord, and inject it into the next monkey in order for even half the monkeys to get sick. They wouldn't even all get sick. And we knew there was polio in the spinal cord. If they took the spinal fluid, nobody got sick. If they took the spinal fluid and tried to culture it, they couldn't find the polio virus. It's very difficult to isolate out of the spinal fluid because it's an RNA virus, and the science of RNA viruses are such that it's just the RNA breaks down and it's very difficult to isolate. So how do we prove when one of these enteroviruses, how do we prove that it is causing illness? And if it is, which enterovirus is causing it? And this is where it gets difficult. So we use a combination of epidemiology and science, and we put the two together to make our best guess. And so, or at least at the stage we're at now. So when we have tested all of the kids who have been evaluated for acute flaccid myelitis even going back to 2009, 10 through 2012, when there were some cases being identified out of California and shared with the CDC, all examinations for polio in any of its form, the polio virus, tested negative. Looking classically, the polio virus will shed in the stool of a patient with polio for a period of time. And even when looking at stool samples, they couldn't find it. And these, it is worth noting, the overwhelming majority of children who've had acute flaccid myelitis have been vaccinated for the polio virus to begin with. And if we look worldwide at the success rate of the polio vaccine, it is outstandingly good at preventing polio. And so right off the bat, polio seemed to be an unlikely culprit. At the same time, however, there were a number of kids who were testing positive for an enterovirus, the so-called enterovirus D68, and they were testing positive from a respiratory swab. And this is where the families of viruses get to be important. So there are some enteroviruses that like to live in the nasopharynx, in the nose, in the back of your throat, things like a rhinovirus that causes a common cold, what I'm getting over right now. And then there are some enteroviruses that like to cause GI illness, stomach illness, and they have to be protected against the stomach acid in order to get down past your stomach into your small intestine and give you the diarrhea that we all hate when we have a GI enterovirus. It turns out that enterovirus D68 specifically looks more like a rhinovirus. It is acid sensitive. It does not cause as much GI illness in folks. It really causes respiratory infections. It can do either, but where we see it the most is in the nasopharynx and with respiratory infections. And when we swabbed kids who had acute flaccid myelitis, in a lot of the children, we were finding enterovirus D68 in their nasopharynx. Now, this is where there's a lot of controversy because you'll go onto certain information websites, places, and they'll say, listen, Ben, less than half the kids swabbed for this virus tested positive. It's just out there. It's not causation. And the issue comes in the timing of the swab. So it turns out if you look at kids who had acute flaccid myelitis and they had their nasal swab on day 1 versus day 5 versus day 10, 15, 20, 25, the longer you wait to send the test, the less likely it is to be positive. So if I include every child with acute flaccid myelitis who was swabbed at some point during their hospitalization, less than half test positive for enterovirus D68. If we take kids, and this is work that Kevin Messakar out of Colorado has done and deserves credit for it, as you take kids who were tested within 7 to 10 days of onset, the number gets higher than 70% testing positive. And so when we report out everybody who's been tested ever, I think it's a misleading statistic. So now we have an enterovirus that we're seeing in, let's call it at least 2/3 or 3/4 of kids with this form of myelitis. And that's the epidemiology. And then we have to ask the question, can the virus cause what looks like polio? Because for all the world, this looks like polio. And thanks to work out of Ken Tyler's lab in Colorado, there's now an animal model to say this virus causes exactly what polio causes. And what's unique is when Ken's group took enterovirus D68 out of the freezer from the 1960s or 1980s, and then took enterovirus D68 from 2014, the one from over 20 years ago did not cause a polio-like illness, but the one from 2014 did. The virus has changed. This is a splinter cousin of enterovirus D68, which at least in a mouse causes acute flaccid myelitis, very similar to what we see in kids. And so based on what I've seen, both on the epidemiology and the science, I think that the most likely explanation for a lot, if not the majority, of kids who've been affected by this is enterovirus D68. Now, do we have that conclusively proven? No, based on isolating D68 from the person in the spinal cord. Do I think we will have it proven in that way? No. And what I remind people is when we're trying to prove polio, we don't isolate it from the spinal fluid or the spinal cord. The diagnostic criteria for polio says you have to have acute flaccid weakness and the poliovirus in your stool. And what we're advocating for is the exact same level of criteria to say you have to have acute flaccid weakness and enterovirus D68 in your nasopharynx, and use that as a marker for saying there is or isn't an association. We're working with colleagues in Europe. We're hopefully going to be meeting with them face to face in the springtime to come together to put together an international consensus on how we're going to sort through this epidemiology. Because ultimately, what we as a community have to decide is, should we be investing in a vaccination program for this virus, just like we did for polio? And in order to justify that, we have to convince people that there, A, is a link, and B, the virus has the potential to become more widespread or more virulent in the future.
Thank you so much for clarifying that. That's, I think, really helpful. You mentioned the epidemiology of AFM and sort of talking with people in Europe. So, there's definitely been, along with the spikes that you've noticed epidemiologically of patients, of kids in 2014 and 2016, we also sort of see spikes in parents who are joining the group, sort of as new kids get affected. Can we talk a little bit about two things? One is what we're seeing in Europe, because there are a few parents who have been joining the group from Europe, and then also how you advise new parents and new families versus kids who were affected a few years ago on what to expect from rehab, what to do with interventions, how to talk to insurers about getting different therapies covered, and then there's often questions about supplementations, and I know I think you might have a few favorites, so we'd love to hear about those two things too.
So the easy questions, got it. Okay, got it. So
just for you.
yeah. So first off, relative to Europe and the United States, I think what we're seeing in at least Northern Europe, Northern and Western Europe, and including the UK, is essentially identical to what we've seen in the United States. Kids more affected than adults, flaccid weakness with or without brainstem involvement, combinations, and I have to stress, very important, the huge number of kids who have a combination of flaccid weakness in one limb, but what's called upper motor neuron weakness in other limbs. What I mean by that is, instead of the anterior horn cell being affected, the connection between the anterior horn cell and the brain being affected, which gives you a different pattern of weakness, that stiffness I've talked about. And so the phenotypes, the types of symptoms, the types of kids we've seen are almost identical from all the interactions I've had with my European colleagues, and so much so that we're working on getting everybody in the same room at the same time so we can compare and contrast our data and see if there are any differences. Relative to what we're seeing in terms of recovery, there is, I think, a massive amount of misinformation being perpetuated around recovery. So I can look you in the camera, not in the eye, look in the camera and say, overwhelmingly, almost all, I don't want to say all, although in my gut, I think it is all, of our kids are showing signs of recovery from their worst point. It is, for the flaccid limbs, slower than the tight limbs. And the recovery we're seeing in the tight limbs is directly proportional to the amount of rehab and work that kids and families are doing. What we're seeing in the flaccid limb is less directly correlated. I think there's a lot of variables that dictate whether or not those limbs are recovering quickly or completely or slowly or incompletely. And what we're looking for is for physical therapists and physiatrists to recognize that the limbs are different, that what we do for the tight limbs is different than what we do for the loose limbs. And for people to get a little creative and think outside the box in terms of what we're trying to achieve. And part of it goes back to the anatomy and the physiology of how the nervous system and the muscles work. So without geeking out too much, let me give you kind of my version of things. So you have a muscle. It could be your biceps. And within that muscle, there are a lot of individual cells. We call them myofibers. There's tens of thousands of individual cells that make up your biceps. those fibers are innervated by cells that originate in the spinal cord, and those cells in the spinal cord live over about 3 inches in height. So you can think of a cigar-shaped group of cells where there are some from the top and some from the middle and some from the bottom, all going to the different fibers in the biceps. But it's not a one-to-one. So one cell in my spinal cord will innervate potentially 100 fibers in the biceps. Okay, so out of those 10,000, 100,000, million fibers in my biceps, there's going to be 1/10 the number, 1/100th the number of cells in the spinal cord going out and innervating. Whenever there's damage to those cells in the spinal cord, as best I can tell, and as best I've seen both in animal models and in our experience from polio and in other cases, the virus, the immune system, never kills all of them. It is actually extremely difficult to get them all destroyed. That would be a massive injury. So we are going into this, my clinic is going into this with the assumption that the majority of our kids who have a flaccid arm have killed cells over that 3 to 5 inches of spinal cord, but not all of them. So if that biceps that used to have, I'm making up numbers now, but used to have 1,000 neurons going to it, only has 800 going to it, what can we do to get the 200 to take over the job of 1,000? So this is about compensation. This is about promoting repair. This is about biologically the notion of sprouting. So it turns out that if a neuron is attached to my biceps dies, one of its neighbors starts to take over. But it doesn't do it just for the sake of doing it. It's not genetically encoded to do it. It needs to be asked. And so this is where the therapy comes in. This is where electrical stimulation comes in. This is where what we use, the activity-based therapy, comes in. Our sense is the more we ask the muscles to contract, the more we ask the neurons to sprout, the better the recovery we're seeing. This is theory, this is not fact, but it's been the theory we've been operating under as we're putting our kids through rehab. And what we're seeing is repetition matters. So what I'm telling families is if you had to choose between 1 day of very long, very intense therapy versus 7 days of light therapy, do 7 days of light therapy. That it's in the nervous system from a repair and plasticity perspective, the repetition of doing it is more important than the big intensity of doing it. I'd love to see big intensity every day of the week, but we all have to go to school and lead lives and go to Disney World every now and then and do fun things. But even at Disney World, after you come back from Magic Kingdom, in the hotel room that evening, there needs to be some form of therapy because the repetition matters. And what we're seeing are our kids improve. And what we're struggling with is what do we intervene with and when? So I'm sure we'll talk about nerve transplants and other things. There's a time window that seems to be best for nerve transplants, and that window is a little different depending on who you ask. And so we're trying to decide in the first 9 to 12 months, really, how much natural recovery are we seeing to decide what other levers can we pull to promote recovery. But in general, repetitive therapy every day on every limb matters. Now, getting services covered is a huge issue here in the U.S. and in Europe. And what I'm asking families to do is to get a partner on the clinical side to advocate and write letters and appeal and do all those things, but then to be smart with whatever resources their insurance gives them. So, for example, if your insurance says we will give you 60 days a year of outpatient therapy, and in policies it's literally written this way, how many days per year they will give for therapy, you can talk to your insurance company about expanding it. You can trade. You can ask an insurance company to say, well, I've got 60 days of outpatient and 60 days of inpatient. Will you drop my inpatient to 30 days and put 30 more days on outpatient? And some insurance companies will do this. Now, you're gambling away the inpatient benefits, but odds are you're not going to need that this year or again if you're already at home. The other thing you can do is you can, in the United States, you can ask to be assigned a case manager by your insurance company. And if you haven't done this already, it's a very valuable thing to do. It is free of charge. They do not. There's no cost to it. It doesn't change your premiums. By law, they're required to make it available to you. And then instead of calling a 1-800 number and getting a different person each time, you have one phone number to one person at your insurance company. So you call up Barry and say, "Hey, Barry, we're trying to get this approved." And Barry becomes your advocate with your insurance company. They're there to advocate for you. So a case manager is very helpful. And then ultimately, whatever your resource is, if it's going to be 10 days, 20 days, 30 days, 60 days, don't use it all at once. So the traditional model in physical therapy after a spinal cord event is to get people into therapy every day of the week, an hour a day, 3 hours a day, and then at 6 weeks, the physical therapist says, "Well, you're not making progress," and they just send you home. And everyone's just kind of left looking around saying, "What do we do now?" We're taking a very different approach, which is to say, all right, if you have 60 days, divide by 12 months, that's 5 sessions per month, that's 1 to 2 per week, spread it out over the year, and think about your physical therapist as not the person who is going to get your child better, but the person who is going to teach you how to do therapy on your own at home so your child gets better. What I tell folks is you do not get better by going to therapy, you get better by doing therapy. And it does not have to be in a gym, and it does not have to be with a physical therapist. The point of the physical therapist is a month later, 2 months later, when something is improving, they should be changing your regimen, making it harder. Nothing drives me nuts more than seeing a note from a physical therapist that says, "Billy met his goals, discharged from therapy." To which I say, if Billy met his goals, let's change the goals. Let's up the bar and keep going. And that's up to you, the families, to really push and make sure that we're constantly setting the bar high enough, but spreading out the therapy over time. Having somebody come in and correct form, correct posture, talk about different techniques is a very worthwhile thing to do. In Europe, the situation is different. I'm learning as I work with colleagues and I've interacted with some families. I'm frankly a novice at learning how to navigate the European health system. What I'm hearing from colleagues over there is very similar to in the US, you need an advocate. And so finding a clinician who's willing to write the letters or advocate, that's going to be key, because I seem to hear about a lot of brick walls over there and a lot of obstacles to getting certain types of care instituted.
Thank you. That's so helpful. In terms of supplements, I've
Yeah.
seen some mentions of alpha lipoic acid or choline or various things. What do you tell parents? What do you advise?
Yeah, so I always start with, obviously, we have limited to no data depending on which supplement we're talking about. Mm-hmm. So I start with a list of ones that we have good safety data on and then branch out from there. So the three that we probably have the most comfort with, so vitamin D3, and that's frankly a little bit of a stretch. We're using it mainly on the chance that somebody has had an immune-mediated attack, and not a virus in the spinal cord, but an immune-mediated attack on the spinal cord. There is evidence to say that if you get your vitamin D3 level up between 50 and 100 nanograms per mil in the blood, it reduces the chance of future inflammatory events of the spinal cord or the brain. So the D3 is there to cover ourselves in case somebody had an immune-mediated event. I don't have any data to suggest it helps with repair function. Alpha lipoic acid, there's a very old Russian study of diabetics with peripheral neuropathy. So this is pretty much as far away from acute flaccid myelitis as we can get. But what they found was it promoted sprouting and repair of nerves in the periphery. And in the adults, they used a dose of 600 milligrams twice a day. There isn't a standard dosing for kids, and so we try to back channel and make it up based on weight, but its safety profile is extremely good. And so we have been using alpha lipoic acid on the chance that if it is promoting sprouting or repair of a peripheral nerve injury, that there may be benefit in the setting of acute flaccid myelitis. And then the third supplement we've routinely talked about in our clinic is omega-3 fatty acids. And that's really for the kids who have had damage to the wires connecting the anterior horn cells to the brain, because the omega-3 fatty acids are used in the repair and regrowth of myelin, the coating around those nerves. And it's got a huge safety profile. well. So those are the three we've routinely used or advocated for in our clinic, admittedly with limited data. Choline, I don't have data one way or the other, help, harm, or otherwise. The one thing I will say, and I do get on a little bit of a soapbox around supplements in clinic, is two things. Number one is they are drugs. Even though they are labeled as supplements, that is a legal term. They are a substance we are putting into body. Food is medicine too. We spend a lot of time talking about diet. So anything we are ingesting, whether it comes from a big bad pharmaceutical with a CEO or a nutritional supplement company out of somebody's garage in Austin, Texas, these are all medicines, and all of them carry risk, no matter what their label is. And so we're always very cautious about it. We always like to only start one at a time, not multiple at once. So if there are side effects or issues, we'll know what caused it. To be sure that people are transparent with their treating clinicians about what they're taking in case there are known drug-drug interactions. We have had patients in our ICU due to supplement intake. And so there are things that are toxic. Best example, B6. Everybody likes their B vitamins. B6 in excess is neurotoxic. I've had patients in wheelchairs from B6 neurotoxicity. And so just because it's over the counter does not mean it is completely safe. So do invest in conversations with your healthcare clinicians. Some of them will be dismissive and just say, it's a lot of crap, don't take any of it. And unfortunately, that comes from us, and I include myself in there, having no formal education whatsoever in these agents. And so you have to obviously partner with a clinician who will at least have a conversation, but recognize there is danger to all of these things.
Mm-hmm. Got it. It's funny that you say, food is food is supplements too. When my son was very sick, coming into rehab, he ate like 6 hard-boiled eggs a day. And I think it was like this attempt to put on protein himself. And then when we got out of rehab, he hasn't touched an egg. But he was demanding these eggs. I have one more question for me, and then I would love for the parents to unmute yourselves and start asking some questions. One more question for me is, as our kids sort of move out of the acute phase and into the sort of slow, rehab phase, there has been some mention of limb length discrepancy, and I have seen, and certainly my son has that with several of his limbs, and also the concern about osteoporosis in the affected limbs. So could you talk a little bit about how to look out for that, how to look out for scoliosis, sort of the orthopedic issues, and maybe how we can be orienting our rehab all the way along from the acute phase so that we can try to minimize that.
Yeah, it's a real issue. And so when we were first seeing a lot of kids simultaneously with this and really recognizing the flaccid myelitis as a subset or a variant of the transverse myelitis, I reached out. I've never treated a case of polio. Mm-hmm. So I've seen patients with what's called post-polio syndrome, which is very rare. So I had adults who had polio as children, but I had never taken care of somebody with acute poliomyelitis. So I called a colleague of mine who's at the NIH, but trained originally in India. And I said to him, have you, you've seen polio? He's like, yeah, I've seen polio. I trained in India. Mm-hmm. And I was describing what we were seeing. And he said, yep, that's what we see in polio. And so my background, my undergraduate degree was actually in history. It was the history of medicine. So I'm a little bit of a history buff. So whenever these things happen, I go back and I try to find original literature. And the literature going back to the 17 and the 1800s about what we call poliomyelitis is fascinating and creepy all at the same time. It's literally what we're seeing. It's the exact same thing as what we're seeing. And the resulting limb deformities, length discrepancies, and all the orthopedic issues you mentioned have been literally described for 200 years, and these are longer in these settings. And biologically, what's happening is if the muscles aren't contracting, the bones don't lengthen. And so what we are in a race to do is try to figure out every way humanly possible to get the muscles to start to contract, which is why we're very interested in electrical stimulation. Now, For the electrical stimulation devices that are available currently in the United States, they require, the way their settings are set up is they require an intact, what's called neuromuscular junction to get the muscle to contract. So there has to be a nerve touching the muscle when I put the pads on the skin in order to get the muscle to contract. Well, there used to be devices in the US, and there are some in Europe currently available, where you can change the settings such that you can get a muscle that does not have that junction to contract. So you can take somebody who has that flaccid arm that isn't responding to normal e-stim, and you can get them to contract. And we are working with groups here trying to sort out how do we reset our devices to get it, and there's progress being made on that. The other thing we've explored is something called dry needling with stimulation. So dry needling is, you can think of it as similar to acupuncture. There's a small needle inserted to the muscle, and they use it sometimes for spasticity or pain or a variety of things. But you can take that muscle, take that needle, put it in the muscle, and if you apply an electrical current, you can get a muscle to contract even without a neuromuscular junction. There aren't a lot of physical therapists who've been certified in dry needling, and there are even fewer who are certified or willing to put on the electrical current. So we're working with trying to find more folks to start experimenting with this, because what we think is going to be important is getting muscles to contract as soon as possible in order to avoid those orthopedic issues. And then anything we can do to even get partial contraction is important. So depending on what limb you're talking about, dictates what we do. So if it's a leg, we want kids in standing frames trying to bear weight on that leg as much as possible. Even partial muscle contractions, even if it's not enough to support somebody's body weight, makes a difference for bone growth. The arm is harder. From a rehab point of view, there are bikes, hand bikes that can be used. You have to be careful around keeping shoulders in socket. So if you have weakness over the shoulder, if you're going to be doing a hand bike, you really need to talk to your PT about using what's called kinesio tape to make sure that shoulder is in joint as they're doing the bike. But those are some of the things. And then aqua therapy, therapy in a pool, turns out to be very helpful because it takes gravity out of the equation. We have kids who can walk in a pool, who can't walk on land, but they're learning how, and that's activating muscles. And so anywhere we can go to get muscle activation, we do it. That said, there is a chance for orthopedic complications after a flaccid myelitis. So getting established with an orthopod to monitor things is important. In the world of scoliosis, what we've been saying so far is as long as there is no compromise of lung volumes or breathing, and a child is still flexible and can get into all positions, we are monitoring the curvature. We are trying to avoid rod placement as much as possible. But if there's ever compromise of breathing or lung volumes or losing flexibility, then unfortunately we have to talk about scoliosis surgeries.
Thank you. Very helpful. Parents, do you guys have questions that you want to ask Dr. Greenberg? What you'll just have to do is unmute yourselves if you do. Just going to give them another little bit.
Are there any clinical trials coming?
Mm-hmm. Yeah, so it is a good question. There is a clinical trial coming for the long tracts that have been damaged. So for people, if there are individuals who have limbs that have the tight weakness or sensation loss, there will be the announcement for a clinical trial coming in early 2018. It's a phase 1 trial. It's going to enroll adults first, but a way to repair spinal cord damage for those long tracts. We are discussing, there were some old studies we did over a decade ago on regrowing the anterior horn cell. And we have started the conversations to dust those off the shelf and bring them back into a position where we could talk about doing it as a clinical trial. But that conversation is probably going to need about 6 more months. Because we need an FDA-approved source of these cells, and that's the tricky part.
Okay. There's nobody asking. Our daughter has issues with the bowel and the bladder. Over time, have there been any improvement at all?
Mm-hmm. Yeah, the majority of our kids, the key is to actively manage it, not passively manage bowel and bladder. So what do I mean by that? Let me talk about bowel first. So the bowel can be trained to empty at the same time of day every single day. And if you get a bowel to do that, what you end up fixing is you avoid the constipation, which can be a real issue, and you avoid incontinence, which can be an issue, because for the rest of the day, the bowel is empty, basically. And so the key to a bowel, the colon can take on a mind of its own and literally just empty same time of day every day. But it takes practice and what's called a bowel regimen. A really good resource for a kind of do-it-yourself way to approach the bowel is on the Christopher Reeves, the Dana and Chris Reeves spinal cord website. If you go to their website and under resources, you look for bowel program, the group wrote a very nice list of tips on how to get control over bowels after a spinal cord event. So that's a great place to go online and to read about and look at. The bladder is a little different. The bladder, there can be a couple different patterns of bladder dysfunction after there's been inflammation in the spinal cord. And depending on which pattern a person has, there are different treatments. So usually we need our kiddos to get seen by a urologist who understands neurogenic bladders, so they can tell us which pattern we're seeing, and then we can guide folks on how do we work to improve the bladder. One of the issues that happens in some of our kiddos, if it's not evaluated by a urologist, is they develop a neurogenic bladder with a very small bladder that has no capacity. So if it fills even a little bit with urine, they instantly squeeze and try to empty everything. Other kids get big floppy bladders that aren't squeezing. And so depending on which pattern is going on, we have a different way of trying to coax it along. But the overall majority of our kids, the bladder is improving over time.
Okay, thank you.
Other questions?
I'm just going to keep asking.
Oh, good. All right, keep going.
Autonomic
dysreflexia.
Dysreflexia she has now.
Yes.
So she's been, 2014 she was diagnosed, and the autonomic is probably 14 months old, 14 months now.
Yep.
And incomplete spinal cord T8, T10.
Mm-hmm. Yeah. Yeah. So autonomic dysreflexia is actually a little unusual below T6. It can happen. Usually, our folks with ADR are above T6, but it can definitely happen anywhere in the cord. Usually, the issue with ADR is trying to sort out the trigger. The top 2 triggers are bowel and bladder. The third is pain or wounds, some type of lower extremity issue around pain or wounds. Those are usually the top 3 that would trigger autonomic dysreflexia. So the starting point in our clinic is trying to identify the trigger, and far and away number 1 is constipation. So if somebody has impacted bowels, even if they don't think they're impacted, we'll get an X-ray in the clinic and we can see the colon's full of stool. There's really no way to get control of autonomic dysreflexia unless the bowel is really cleaned out and constipation is dealt with. If we get somebody where the bowel is working perfectly and there's no constipation and the bladder's working well and there are no urinary tract infections happening and it's not associated with cathing, then we'll start talking about medical management of autonomic dysreflexia independent of the trigger. But we really look very hard for the triggers because when we find them, it tends to get rid of it almost completely.
Could the scoliosis be a trigger?
I don't know if scoliosis in and of itself being a trigger unless it's impacting bowels or breathing. But just being there, I don't know of it being a trigger.
All right. Okay. Well, I know you have patients to get to, and we're so grateful for your time. This has been so informative. Thank you very much. So, Dr. Greenberg, UT Southwestern, thank you.
Yep.
Thanks for
No,
all
I
you're doing.
appreciate it. I appreciate all the work you guys are doing. I know everyone is working hard on this, and there's a lot of unknowns out there. Anything we can do to help, partnering with you guys and obviously Transverse Myelitis Association and any of the organizations out there that are trying to improve things for all of our kids, we're happy to play our role. So if there's ever anything we can do, just let us know.
Okay. Thank you very much. Okay.
Thanks.
Bye.
Take care, everyone.
Bye, guys.